I'm Frank Vajda. I'm a neurologist and a clinical neuropharmacologist, and I'm working at the Royal Melbourne Hospital at the University of Melbourne, and I've also been appointed to Monash, but my work is at the Royal Melbourne and I run a private practice. And I've been trained in clinical pharmacology, which means the use of drugs, and neurology, which is the study of and treatment of people with nervous diseases, nervous system diseases. And my particular specialty is epilepsy or seizures and the treatment of epilepsy. And in particular, because epilepsy is very common and half the people who have this condition are women, we are particularly interested in what happens to women in pregnancy and what happens to their babies when they're taking anti-epileptic drugs. And the aim of this study is to discover which are the safest drugs and which are the drugs which are able to control the seizures for the mother, as well as don't present a risk to the baby, so that the baby is born normally and the mother is free of seizures. And it's a very difficult balance, but if you're successful, you improve the quality of life of the women who are the sufferers, and you produce healthy babies. And we know that different drugs have a different potential for causing problems. And we established a voluntary observational study of what actually happens in the real world 20 years ago. And we are trying to find out if some drugs are worse than others in producing malformations. That was the primary aim. Make sure we find out which are the most dangerous and try to avoid them. And then out of that arose a number of problems which we are trying to solve, like how to reconcile a safer drug with seizure control, how to prevent physical malformations like an extra finger or an extra limb or a hole in the heart, to prevent that and at the same time maintain control for the mother. And then what happens if the mother has a child who is defective in the sense that something is wrong physically? What happens in the next pregnancy? Does that particular malformation recur? So is there a chance that a particular drug is very dangerous, not to all women, but to that particular woman and her family? So is there a family difference in response to certain drugs? And then we try to find out what happens if somebody with epilepsy is perfectly controlled for a year prior to pregnancy or 2 years prior to pregnancy, and we found that seizure freedom before they become pregnant is very important. And if they are seizure free when they become pregnant, the chances of having a good pregnancy is much more likely. Then we looked at a number of other things arising out of this in relation to autism, which some of the drugs may be responsible for, which are the drugs which in high dose, but not necessarily in a low dose, cause malformation, which drugs should be avoided absolutely, whether certain drugs are safe in lactation or suckling the baby, breastfeeding, or is any of them contraindicated. And we found that with the vast majority of drugs, suckling or breastfeeding is in fact permitted, because it produces bonding between mother and baby. It produces essential foodstuffs and antibodies to infection, which the baby, when he is born, she is born, is lacking, because they don't have the protection which comes acquiring the infection to even to a mild degree and producing antibodies to it. And then we looked at what happens, why is it, if we can determine that some babies are stillborn, aborted, why some women become untraceable, so in other words there's a default, we lose them. And we then did studies with some of our students who went on to do higher degrees, whether there is a difference in ethnicity in the people joining the register, but in fact there's a predominance or non-predominance on European ethnic or Indian or subcontinental or Chinese ethnic groups. And if so, is education related to it, understanding what goes on? Is there a language difficulty? And then we try to find out what happens to women who are using these anti-epileptic medications, of which we now have about 15 for non-epilepsy indications such as psychiatric disorders, anxiety, depression, aggression, and so on. So the original comparative safety of anti-epileptic drugs branch out into these 15 or 20 major side issues. Every one of them affect women's health, child health, community health, saves the country money, and we found that in the last 2 years the most dangerous and the most lethal, but they may live with it, so it's not lethal in the sense it kills them, a condition called spina bifida, which means an incomplete fusion of the spinal canal, so that the child may be subject to infection, meningitis, a big hydrocephalus, and then often quadriplegic, needs to be put in a wheelchair. There are several degrees of it. It's not invariable. That's caused particularly by high dose of a particular drug. So by adjusting medications, recommending upper limits for dangerous drugs, and in general altering dosages and treatment modalities and strategies, we have markedly influenced the reduction of these terrible malformations. This applies to cardiac malformation, neurological malformation. Some children get kidney-related malformation, ureter, so-called hypospadias, which means that they piss sideways. You can take that out of the video if you wish, but it's true. So it is a very useful instrument. And we are affiliated with Europe. There are 41 countries affiliated in Europe with the chairmanship of a wonderful Swedish neurologist called Thompson, and with a major group of contributed advisory board, including Professor Emilio Perucca, who's the father of one of our people working at the Royal Melbourne and the Alfred. The boy here is Piero and his father is Emilio, and a number of people from Holland and Italy, Battino and Lindhardt and so on. And we tend to set trends. We ask questions about what ought we do in order to diminish malformations. What should we do to diminish the risk to the women? How can we make treatment more tolerable? What advice can we give? Should we follow the pregnancy only up to termination of pregnancy, like 40 weeks, or should we go on another year? And we found that we miss about 15% of malformations if we stop following that particular pregnancy at 40 weeks, because about 15% of them are picked up after birth. And should we give them folate? That's a controversial issue. Should we give them additional vitamins? Is there any evidence that in fact we need it here? And we find that we don't know, but it's not likely to do any harm, so we recommend giving women folate. But these are all controversial issues. We more or less blaze the trail, and the European or International Pregnancy Register, called EUREP, then checks it out in 15 or 20 times the volume of people who they get referred to, because they represent Scandinavia, France, Italy, Holland, and most of the European countries, Eastern European countries, including Greece, for example, Czechoslovakia, Poland, and so it's very interesting. We are actually part of that EUREP group and publish our data independently from the Royal Melbourne Hospital. And we also contribute data to Europe. We are probably the second or third largest numerical contributor to the European Register, which has now got 35,000 women. Well, we're doing a lot of genetic studies I haven't talked about. The genomic studies, which means the response of an individual to a particular drug. So in other words, is there some reason why a particular genetic composition in the woman's genes reacts badly to drug X? Now, what can we do about it? Well, we can avoid drug X. We can define that this particular drug is not good for the woman, but maybe in the future we can actually predict, do a genetic study on the woman before we give her the drug, and thus eliminate having to give her a drug which produces side effects. And maybe, and this is foreshadowed, and that's a long way away, maybe we may be able to change the genetics. In rare diseases, it is possible to change the gene. That's only been done in a very limited number of examples and is in the embryonic stage. Replace the particular gene early on so the woman no longer has side effects from a particular drug. If, for example, there is a family and you've shown the number of their offsprings are faulty as a result of this interaction, but no other drug controls them, then maybe gene therapy may be helpful. Stem cell therapy, we don't know the details. This is all developing and new, and the people in Melbourne, which is the world center of epilepsy at the moment, may be the ones to find out. Piero Peruca, Sam Berkovic, Terry O'Brien and others.